Our next speaker is Dr. Madhumati Bose. She has an extensive.
Ma'am, I'm not a doctor. I'm just Madhumati.
I'm sorry for that, but I think on this platform, I think I'm sorry for that. And she has 30 years of professional experience in this field, and she's attached to Holy Family Hospital, and also to she's a consultant at AIMS, where she helps in running high risk clinic, and she's a certified in nomoscale diagnostic based treatment, and of course she's a brilliant speaker, and she's at an international level trainer and has conducted several workshops in India and abroad. So over to uh, Madam Madhumati Bose.
Thank you. Thank you, ma'am. And it's an honor to be here and be part of the team. Thanks. So, my topic is visual therapy with multisensory input. Let's start. Next, please. I'd like to start by thanking all the parents, the children, the doctors, the support staff of all the hospitals that I work in, because without them, this presentation won't have been possible. Next, please. I know it's multisensory that I have to talk about, but ma'am, I seize this opportunity to talk about visual protection and stimulation in the NICU, because visual stimulation is becoming a buzzword these days, and at times I think it's very unnecessary, especially for the NICU. Next, please. So we all know there's been a lot of advance in medical science, and the survival rate of our preterm infants, sick infants, low birth weight, small for gestational age have all increased. Next, please. But unfortunately, the environment in the NICU is not conducive for sensory integration or brain development. The environment in the NICU is very toxic. There is not only sound, there is touch, there is smell, and of course, so much of light. Next, please. Next, please. In the in the womb, what happens is the level of, our senses, they come in a sequential manner. They develop in a sequential manner. And here in the NICU, they are bombarded all together. So in the NICU, protection is more important. Please remember, more important than stimulation. If we have to give stimulation, it has to be age appropriate. Next, please. All our babies, especially the ones below 32 week babies, their pulmonary reflexes, the pupillary reflexes are not developed, and this interferes with their development. The intensity and the level of stimulation affects visual acuity, development of color, development of the eyeball, and the retinal development. If we have to give stimulation, the best stimulation is at least give them first protection and then stimulation. Protective lighting has been recognized in developmental supportive care. We have to give cycled lighting where there is 12 hours of daylight and 12 hours of night. So this, they have shown that children, the infants are less fussy, they cry less, they are less disturbed, the, the level of cortisol is reduced, this stimulates the growth hormones, and it has better sleep, and the circadian rhythm follows. Next, please. So if we have to give stimulation, it's only after 33 to 36 weeks when the children start opening their eyes. Let them see their mother's face. Before that, keep them away from direct sunlight, away from the windows, and away from overhead lights. It's only the term babies, the 40 weekers, that we start giving them patterns. I visited AIMS Jodhpur recently, and I saw that it was brilliantly planned, the NICU, where they believed in the daylight, the cycled light system, and the windows were away from there, so they were getting the light at the same time. It wasn't directly overhead. Next, please. It's not only the lights that our infants face; it's also the position. All of our infants in the NICU either have their head extended or to one side, or they're looking at the window. This affects the vision and the position of the head. Next, please. Can you see this incorrect positioning of the NICU of the baby and 5 months later? So obviously the peripheral field at one side is going to be better than it'll be more exposed to the other side. Next, please. Second part, multisensory input for holistic development. Next, please. Vision, we know, affects each and every area of our development. So then why do we, next please, why do we restrict our vision therapy only to 9 to 10 in the morning or 10 to 12 in the afternoon? It has to be throughout, especially for infants, that whether it's seeing the mother's shiny clothes or to reaching for food or even in any kind of position for our children with MDVI, just give them the stimulation each and every moment of the day. Next, please. Vision therapy is not simply torch. Yes, it begins, but it has to move away from there. Next, please. And thank you, Dr. Aditya, for mentioning about the flashing lights. And I know this is going to be recorded. Lights like this, as well as sounds, if the audio can be put, they are terrible. They are not therapeutic for the child at all. In fact, they lead to seizures. Okay, next, please. Vision stimulation. Whenever we give vision stimulation, just remember it has to have lead to visual learning. It has to be meaningful, enjoyable, and functional. Can we see the video? I'm using sound here. This is your question that you asked, sir, at the back, because that's meaningful for the child. But I am not testing yet. I'm just getting the attention. So there was no sound now. That's when I was testing. Adapting the environment is important. Without adaptation, no stimulation is complete. Next, please. Next. Simple adaptation. This is a child from the NICU. First video. Child's looking up, extended head, hands are not coming into midline. Next, please. Position, inclined position. You have a toy stand in front and you hold the legs and the hands will come automatically in front.
Put a ball here also, which he'll try to now. Now do you see his hand, the way it's coming now?
Another thing, our children hate touching textures. They are picky eaters and they don't touch. So for us, vision therapy includes giving them textural experiences also. So it's the orange that they eat, instead of putting in the mouth, let them peel, let them put it in the mouth, let them feel the segments. Next, please. Vision and auditory, again, your question. And this includes motor planning.
हाँ वही है.
He's seen the piano, but I want him
right.
to
हाथ आगे
extend his
बढ़ाकर.
hand to touch it.
Touch piano. Okay. कहाँ है piano? देख कर. देखो piano कहाँ है?
It's the processing. We have to give them time to process.
Okay. अब piano कहाँ गया?
Thanks. Next, please. Play is the best way of integrating the senses and giving them multimedia experience.
More right and left. Huh? Okay.
So this is communication, this is balance, and this is vision altogether. So this is Mishti. She is a reader in class. She's a writer, reader. But I want to show you that when it comes to everyday life, that motor planning of hurdles, how that interferes. This is our challenge with our children with CVI. You know, they are so good at certain things. And the teachers, and thank you for saying it earlier, Dr. Sudha, that the teachers, unfortunately, they don't get an idea about our children. ये तो पढ़ सकती है, but what about when it comes to crossing?
करके जा रहे हो मेरे पैर को. Wait. Okay. चलो. आओ. ये नहीं करो.
Generalization. Just because they can recognize a ball in one place does not mean that they can recognize a ball in another situation. And to make it from simple, like you said, Dr. Aditya, to simple to complex is what works for our children. Don't show the videos, it's okay. Therapy in different settings. It's not only the room setting. We have to take them outside because after all, they can't just be in a classroom or in their house. So give them experiences outside. That gives a holistic. Please see this. Sometimes we don't want to leave it till last. That जब बड़ा होगा तब वो कर सकता है. How to hold a cup, how to pour.
चलो. Handles. Very nice. Very nice. Very nice. Okay.
Danga? Hello, Danga?
हाँ. Very good. Count करके count. ठीक है, सही है, सही है, सही है. करो. 1,
2, 3, 4, 5.
stop. सही तरीके से रख.
You know, our children learn. Don't write our children off. You let them practice. They will accomplish and they will learn the task.
प्लेट भी तो देना है ना मुझे. कप और प्लेट दोनों एक
These
साथ
are little things which we as parents, as teachers, we do for the child. But in the long run, it doesn't work. They need to do it themselves.
गिरने वाला था. कुछ नहीं होता. मेरा हाथ यहाँ देखकर मेरे हाथ में दे.
बच गया मेरे कप से.
हाँ, बच गया. मेरा हाथ कहाँ है?
Next. This is Nehal's story. She comes from Kashmir and she's progressed so much. But I want to tell you later what happens. Just see this. This is. Yeah.
सुनो. लेस चाहिए. लेस.
She could differentiate between Lay's and Uncle Chips, which I don't think I can till now.
बहुत सारी चीजें हैं यहाँ. लेस देख लो अच्छी तरह. लेस. चलो एक एक करके.
और पुल बॉक्स देखो कहाँ.
ओनली रसभरी. हाँ.
So there are times she's not looking, but that's okay. You can't expect her to look
और रसभरी का है.
100 out of 100 times.
वेरी नाइस. कहाँ है हैंड? कहाँ है कमला दीदी की हैंड? कहाँ है? देखो रसभरी कौन सी है?
यस गुड. अच्छा रोजबेरी.
रस.
We gave her experience of peeling the coconut husk, everything, touching finer things. She wanted to explore our campus. And she wanted to climb a tree. This is vision therapy for me. But unfortunately, she got one seizure and she's lost everything. Next, please. One of the main things about therapy for infants, for children, is early intervention and parent support. Unless we support parents, no therapy will work at all. They're torn, they're running from one place to another. Next, please. Home visits is very important part of our visual therapy. Thank you to our parents and our children. Without you, we are nothing. Thank you. And thank you. And I'm sorry I took extra time. Thank you.
Thank you, Madhumati, for that excellent talk. You got out a very important point, and I think we'll all agree that the mother is the first teacher for the child. The mother is the first teacher. The mother is, there round the clock, and It's so important to have small hints and train the mother so that the therapy is are they taken care at home also and in the clinic also as and when required. It's a very important point that you got out. And another thing I wanted to know from you is the NICUs, whether you showed different postures, where the child should get the right posture. Is it in coordination with the pediatric neonatologist that you're working with? I mean, because there are some positions which the pediatrician and the neonatologist may or may not.
Agree. Yeah, I agree that there are certain positions that the child has to take. But because of that, if at least after that situation is under control, if we can change the posture and just not change the posture because the child needs and not just let it be as it is. So we do need to give that input, at least make the doctors, nurses aware, because we are getting children in the high risk clinic where if they are faced this side, usually they are on the right side, so the right temporal and the left temporal is okay and the right, but here the left peripheral is not just working at all, so that's the reason.
Do you have a standard format or some structure which could be put up in the major units of the NICU in the country?
Yes, AIMS has done this thing, 7-part video on developmental supportive care. This is part of developmental supportive care. And what are the stress signs? How do you change the position? It is there. It's
Yeah.
and I don't know how much it's been following everywhere. So
I think it will be a very good, idea to have it in all the NICUs in the country.
it would really help if developmental supportive
Yes.
care
Yeah.
can take over. Thank you.
Thank you. Any questions from the audience?